we had originally planned for this program to have a different lecture, and we've been unfortunate we lost 2 of our lectures. But we felt that, given that the AREDS2 data has just been published at ARVO, that it would be interesting for you to maybe see what the data has shown and how we interpret the data. The day after the AREDS data was presented and published, I think I read about 6 different press releases, and they all said very, very different things. And we've already seen a snapshot this morning from Stephen in terms of the complexity in the design of the AREDS, and it is a very difficult design. But we're going to try and talk through it a little bit and go through the main findings of what we believe AREDS has shown, even given the complexity. So what does it mean for eye care? And I think that's important, because what I've seen when I've been working with optometrists across the UK and Ireland over the last number of years is they talk a lot, obviously, to the ophthalmologist, to the medical ophthalmologist. And medical ophthalmologist, the primary recommendation is, well, what did the biggest study show? You know, what did the biggest study show with the most people? And, you know, while that's understandable because it has more power and that, it's not always the best way to understand nutrition for the eye. So I think it's time now to look at it in terms of, you know, what can we learn from AREDS, and how can we look at that in the context of the other small, more focused carotenoid trials that have been conducted across the globe. So AREDS1, we learned this morning that this provided proof of concept that antioxidants may have a role to play for age-related macular degeneration. And this landmark study had 3,640 patients, aged 55 to 80 years with AMD, and 1,117 controls. It was a multi-center trial, and the vitamins and antioxidants used in this trial were vitamin C, E, beta-carotene, which has got a lot of debate and conversation, zinc, copper, and there was no macular carotenoids used in the original AREDS formulation. This massive trial was funded by the NIH, the National Eye Institute. The categories of AMD that they looked at ranging from controls essentially free of any symptoms all the way up to advanced AMD in one eye. And as Stephen said this morning, that disease in the fellow eye is a very high risk factor for AMD. So if you have disease in one eye, you're very likely to get it in the other eye. Here's a breakdown of how the study medications were given. You had antioxidant group, you had 500 milligrams of vitamin C, vitamin E, beta-carotene, 15 milligrams of beta-carotene, which is quite a lot. Zinc, 80 milligrams, 2 milligrams of copper, and then a combination of both. And then you had your placebo. So you had 900 people in your placebo, so nearly 1,000 people. So there certainly wasn't an issue here with power. So if there was an effect to be found, this study was designed to find it. They did take tablets, divided, 2 tablets were taken daily. And they were additionally allowed to take Centrum tablets. So there's a lot going on here in terms of the vitamins and the antioxidants that were used. Data collection, annual assessment, ophthalmic examination with fundus photography, measurements of visual acuity. And we spoke this morning about visual acuity and how it's important for measuring visual function, but it doesn't give you the total picture. Measurements at 6 months there. The comparison here of main effects were antioxidants versus no antioxidants, zinc versus no zinc, and each active treatment versus the placebo group. This is the famous slide from AREDS. This is the one that would have been used to kind of show the main effects, and the punchline is that antioxidants plus zinc showed the best effect, 25% risk reduction in terms of progression. But the carotenoid scientists would have been, I suppose, critical of the formulation used because, as I said early on, it didn't contain lutein zeaxanthin or mesozeaxanthin, which makes up the macular pigment. So the ideal study, and we learned then this morning about how subsequent studies have used lutein zeaxanthin and now mesozeaxanthin in their formulations. So that was something to do, Karma being one of those. The conclusion from AREDS1, however, is here, 27% risk reduction in vision loss in patients with at least intermediate, so that middle stage AMD, 25% risk reduction progression with at least intermediate AMD. And the proof of concept was set up here, and as we say, this set the scene, it set the tone, and somewhat paradoxically for macular pigment research to grow. It's a really bad picture, but that was us at ARVO this year. there's nothing wrong with your vision. It's a bad picture. That was us at Arvo. We went to Seattle to see the AREDS2 data, the long-awaited AREDS2 data. And this is Dr. Emily Chu, who will be joining us during the week for our scientific event, who presented this data. To put it in context, I think the AREDS study cost something like 200 million or something ridiculous like that to run. So you can imagine the interest that was there on that. The publication came out pretty much that evening, or if not the day after, I think. And let's just quickly look at the study design of AREDS2. Multi-centered, randomized controlled trial, so strong study design there. Medium of 5 years follow-up, so long follow-up, which is what you need. We spoke this morning about the unlikelihood of finding changes in progression in, say, 12 months or even 24 months. So this was a 5-year trial. The primary measure here, and Stephen will talk about this in more detail, but progression to advanced AMD. We'll be careful in how we describe and explain that because it's quite tricky in this context. But then they looked at, of course, secondary outcomes in terms of visual acuity. Again, the measure of visual function here was just visual acuity. There was no other measures of, say, contrast sensitivity, etc. Lens opacity, vision change in advanced AMD, the effect of AMD of eliminating beta-carotene. So they did a lot with presence or absence of beta-carotene. They wanted to see could they find different effects. This is very complicated, and you know, as we said, the study design was very complicated. I would have been very interested in the top line here, which is the primary randomization. So you have your controls, you have your lutein and zeaxanthin group, you have your DHA and EPA, which is your omega-3s, lutein, zeaxanthin plus DHA and EPA. So that's for me, a very interesting research question and one I'd like to see the answer to. But what we've seen with AREDS is that all these people were then given the original AREDS formula or a variant thereof. I think there was only 19 people in the whole study that actually chose not to take the original AREDS and were put on control. So there was only 19 people that actually had what we would call a true placebo. So I suppose the conclusion from the design is that there was no true placebo. You're looking at a big cocktail of antioxidants, whatever way you look at this. And here the primary randomization is summarized. You can see 1,000 people were given lutein and zeaxanthin. Over 1,000 people were given omega-3, DHA, and EPA. And then the combination, and then the control. But again, just to point it out, the control group were not a true control because they were given the original AREDS formula or a variant thereof. And then, which is summarized here in the secondary randomization, as you can see here, there's only 19 people that actually were what I would consider a true placebo. And this is now where we move to Stephen presenting the actual results. These are the slides complimentary of Dr. Emily Chu. She's allowed us to use the actual slides that she used in her presentation. So Stephen, I'll hand it over to you now to go through the results.
Okay. So thanks, John. And just once again, ad nauseum to contextualize it, there was no control group. Okay. Everybody in AREDS2, except for 19 people who happened to refuse, got AREDS1 formulation. So it was not placebo-controlled. So they either got AREDS1 formulation and lutein and zeaxanthin, or AREDS formulation and placebo, or AREDS formulation and omega-3, or AREDS formulation and lutein, zeaxanthin, and omega-3. And then just to make things a little bit more complicated, some of the AREDS1 formulations were changed. On some of them, beta-carotene was taken out. On some of them, zinc was reduced. And on some of them, beta-carotene was taken out and zinc was reduced. Okay? It's very, very hard to understand, but that's it in a nutshell. Now, the most important thing and the fundamental flaw, in my view, in AREDS2 is that it was too ambitious. They found that there was a 25% risk reduction of progression to advanced AMD in AREDS1. So they said, okay, for AREDS2, we want to see that same 25% risk reduction and another 25% risk reduction, as if it was an additive effect. It's not, it's complementary. So it is not surprising at all, A, given that there was no placebo group, and everyone was given the original supplement or variation thereof, which is shown to work, that just adding in lutein and zeaxanthin or omega-3s into one arm of that would have an additional effect, and unsurprisingly, it didn't. So there's the primary randomization, more or less 1,000 in each group. Control, which is not a control, they still got the AREDS1 or variation thereof. Lutein and zeaxanthin and an AREDS1 type supplement. Omega-3 and an AREDS1 type supplement, or lutein, zeaxanthin and omega-3 and an AREDS1 type supplement. The only exception is 19 people over here who said, no, we're not having an AREDS1 supplement. It's such a small number, it doesn't count. The way the data was presented, which is a nice way of presenting it, is as follows. If this is a treatment, so let's say, for example, this is lutein and zeaxanthin, and that is placebo. If it doesn't cross the line, and it's all to one side, then that's good. If it crosses the line, then it's neither good nor bad. But if it doesn't cross the line, but it's on this side of things, it actually did harm. So that's largely how the results are presented. So let's look at the primary outcome. So did using lutein for any of the 4 treatment options on top of an AREDS1 type supplement result in an improvement in terms of progression of AMD? And the answer is it did not. And that's shown here if you look closely. So the placebo, which again is not a placebo, is more or less the same as the others. There's a slight improvement with lutein and zeaxanthin and with lutein, zeaxanthin and omega-3s, but not statistically significantly so. So then they looked, and they had pre-planned this, so it is legitimate. They looked at secondary outcomes. So the secondary outcomes are, first and foremost, if they just divided the whole group into those who got lutein and zeaxanthin versus those who did not get lutein or zeaxanthin, there was a benefit associated with those who did get lutein and zeaxanthin, a reduction of 9%, which was significant in terms of progression to advanced AMD. So that's good. They then, and quite sensibly, divided the dietary questionnaires at baseline into quintiles. So if you had an appallingly poor diet and you were in the lowest quintile, you probably had very little macular pigment, even though they only measured macular pigment in 150 out of the 5,000 subjects. But you probably had very poor macular pigment, very low macular pigment. So you were probably going to benefit more than others, and this turned out to be the case. So participants with lowest dietary intake of lutein and zeaxanthin showed a statistically significant reduction of 26% in risk of progression to advanced AMD when compared with subjects not receiving lutein and zeaxanthin. And interestingly, this is also remains true if you divide it into tertiles or deciles. Okay? Then they looked at, and this becomes explained in a few slides ahead, they looked at those who did not, in their AREDS1 supplement, get beta-carotene, but did get lutein and zeaxanthin, so it's almost a subgroup, versus those who did get beta-carotene, but did not get lutein and zeaxanthin. And there's a reason they did this. And the reason they did this is that those who got beta-carotene were found to actually get a significant reduction in the serum levels of lutein and zeaxanthin, presumably because of competitive inhibition. So when they looked at this, there was a statistically significant reduction of 18% in risk of progression to advanced AMD for subjects receiving LNZ in the absence of beta-carotene when compared with subjects receiving an AREDS formulation with beta-carotene and not receiving LNZ. Okay? So let's look at those figures. This is LNZ versus no LNZ in the entire group. And there was a statistically significant advantage favoring treatment in this group, but not for DHA, not for low zinc versus high zinc, not for beta-carotene versus no beta-carotene. Now, the hazard ratio of getting advanced AMD, comparison of lutein and zeaxanthin, anyone who got it in the entire study versus anyone who didn't, was 0.9, and this did reach statistical significance. So there was a 10% reduction in risk of progression to advanced AMD if you got lutein and zeaxanthin. But interestingly and importantly, the other hazard ratios for omega-3s with lutein and zeaxanthin, beta-carotene, high zinc versus low zinc, did not reach statistical significance. Again, this is the dietary quintiles. If you were in the lowest dietary quintile, so you had an appallingly bad diet and presumably low macular pigment, you definitely got a big advantage if you were in those who got lutein and zeaxanthin versus those who did not. And in terms of progression to advanced age-related macular degeneration. So that's looking pretty favorable so far. And this one is, again, progression to advanced age-related macular degeneration of lutein and zeaxanthin. So this is Areds minus beta-carotene with lutein and zeaxanthin. That's the yellow line. And that was significantly better outcome than Areds with beta-carotene. And there should be a bracket in there saying, but no lutein and zeaxanthin. Okay? So again, a significant improvement. So let's look at some other secondary outcomes. There was a significant reduction of 26% in risk of profound catastrophic visual loss due to neovascular AMD for subjects receiving L and Z plus an Areds formulation in the absence of beta-carotene when compared with subjects receiving an Areds formulation with beta-carotene but not receiving L and Z. Okay, so message is coming out, L and Z is good, beta-carotene is bad. And the catastrophic, if you want to avert catastrophic visual loss due to progression to advanced AMD, you should A, take out beta-carotene, and B, include lutein and zeaxanthin. Beta-carotene was associated with poor absorption of lutein and zeaxanthin with consequentially reduced serum bioavailability of these carotenoids. And we'll look at those slides in a minute. And even within this study, okay, the inclusion of beta-carotene in the formulation was associated with a significantly increased risk of lung cancer. So once again, that has been confirmed amongst current and past smokers. So here we're looking, this is in terms of an absolutely catastrophic visual loss. If you were in the Areds with no beta-carotene but with lutein and zeaxanthin versus Areds with beta-carotene but no lutein and zeaxanthin, you are much better off and you are more likely to avert a catastrophic visual loss if you were in this group versus this group. Again, comparison of Areds minus beta-carotene with lutein and zeaxanthin versus Areds with beta-carotene. The vision loss of 30 letters was almost statistically significant. We can see it there. So it's not a catastrophic, but it's a profound visual loss. It was almost statistically significant. And the visual acuity of the catastrophic visual loss, less than 2100, 18% risk reduction in the progression to neovascular AMD with such a visual outcome. Now, competitive absorption of the carotenoids. If you got beta-carotene and lutein and zeaxanthin, but if you got without beta-carotene, there was an increase overall by twofold with supplemental lutein and zeaxanthin. When given with beta-carotene, there was a statistically significant reduction in serum levels of lutein and zeaxanthin. So that explains why the group that was to do best wasn't simply lutein and zeaxanthin versus no lutein and zeaxanthin, but rather lutein and zeaxanthin but no beta-carotene versus beta-carotene and no lutein and zeaxanthin. Now, finally, there was no evidence that supplementation with omega-3 fatty acids was of benefit in any of the analyses reported in this study. Supplementation with omega-3 fatty acids or beta-carotene had no statistically significant effect on visual acuity. And supplementation with L, Z, omega-3 fatty acids or beta-carotene had no statistically significant effect on mortality. And this is all reflected in this. They all cross the line. Okay? So long story short, the AREDS2 formulation supports the view that supplemental lutein and zeaxanthin is beneficial in terms of vision and in terms of AMD progression versus no lutein and zeaxanthin. The evidence also says that we should remove beta-carotene and remove omega-3 fatty acids because they're of no benefit. So long story short, as a result of AREDS2, the eye care profession is now furnished with firm evidence that patients with established, non-advanced AMD will benefit from supplementation with broad-spectrum antioxidants that do include the constituents of macular pigment, and that the formulation should not contain beta-carotene or omega-3 fatty acids. Thank you very much.
So do we have any questions based on this difficult data? Or any comments?
Yes, I got a question. What was the effect of lowering the zinc? I understood that actually there was no difference if you lowered zinc. Now, this is particularly important in Europe, where we can't prescribe 80 milligrams of zinc. I think, according to Trevor, it's 45. So what's your answer to that one?
Yeah, that's right. The low zinc had no detrimental effect compared with the high zinc. So low zinc is now recommended.
So it didn't find that the 80 milligrams functioned better than
No.
the 20. Yeah. Any other questions on that? I suppose one other point to make, given that today we've been talking a lot about macular pigment, is that one of the limitations in my view on this was that unfortunately they didn't measure macular pigment in all patients. There was a subset of patients where they did measure macular pigment. What was very interesting about that, I think it tells us something about the population under investigation here, was that the macular pigment levels measured in those 120 odd people were actually significantly higher than the average norm. So the suggestion, therefore, is that a lot of people that went into the study actually had been supplementing with lutein, and which even makes it more complicated. But I'd be interested in the optometrist view here in terms of what kind of reaction ye had when you heard the data. Has there anyone got a comment in terms of what you felt the punchline was from this study? Yeah.
Well, up to now, one of the big follow-up questions asked me is, when am I going to be able to get this prescribed by the NHS? And up till now, the main impediment to that, which I explained, is that the studies indicate there might be a benefit, but it hasn't been proven to a point where something like the NICE guidelines can allow it to be funded by the NHS. So that's something that popped into my head.
Yeah.
Yeah.
Randy and Richard, would you maybe have a comment? Would you have a comment? What's your interpretation of AREDS2?
Stuart.
I think it's created a lot of confusion unnecessarily.
Can we just get a mic here? Yeah. Sorry, Stuart. Yeah.
I think you know my opinion, so, and Dr. Beatty knows my opinion, but for the group, I think it created a great deal of confusion in the States, because the two presentations by Emily Chu at ARVO, one to our group, the Macular Pigment, the Ocular Nutrition Society Macular Pigment group, and also the main presentation on Sunday, did not reflect what was released to the public.
Yeah.
And I think that was somewhat of a disservice. And it became apparent to me when I read the supplemental material that was online, which is not even included in the main JAMA text. So unless one is using a discriminating eye to look at the data, one is going to miss this point, which you have mentioned, that this was a very well-nourished group, very affluent group. This was a positive study in the lowest tertile of intake of carotenoids. That was clearly the conclusion. And then if you looked at the amount of consumption of lutein and zeaxanthin, that was very high, higher than normal. There were about 20 studies, and this was among the third largest well-nourished group in history of all of these studies. And if you looked at that lowest third, that's about what the average population is intaking. At our Veterans Hospital, that's certainly the average or the norm, okay?
Can you remember the figures on that?
The lowest third, the
Yeah,
lowest third intake. Sure, we've done that because we've done Harvard food frequency intake questionnaires in our study, and we're consistently getting about 2 milligrams of lutein or zeaxanthin intake together. So it's disappointing because the average American is basically getting about 1 or 2 milligrams.
Yeah, that's what I've seen. Yeah.
And that didn't get out to the public at all. The abstract did not reflect, or the conclusions did not reflect what the data was showing and what Emily Chu presented.
Said,
Yeah, so that's my only comment.
I mean, I would agree with every single thing you've said, Stuart. I mean, the other thing is there was one ancillary study from Paul Bernstein's group from the Moore and Eye Centre, which was the small little group of 150 people where macular pigment was measured. And in that small group, that group of people in AREDS2 who had their macular pigment measured, believe it or not, this was at baseline, before they got any supplement, had higher macular pigment than a same population control group from the same city. So it is likely that they were self-selecting to some degree, and they were very well aware of supplements. Also, there was a discrepancy between the published online methods for washout period and the official document with respect to washout period. And if you read between the lines, I get the impression that there was almost no washout period. And that if you'd been on lutein and zeaxanthin supplements for 11 years and you came along to AREDS2 and said, I'd like to be in AREDS2, and I got the impression that you only had to stop for a month, at most 3 months. So 15 years of supplementation is not going to be negated by 3 months of washout. It's just not. You've got a lot of the benefit there. So I was, unlike you, Stuart, I was pleasantly surprised that any benefit was seen in any outcome of this study, because it was so, the data was so polluted from the start.
Thanks. I had a few reactions, and one reaction was that it's very odd to spend $200 million on a study and not include some very obvious measurements, like measuring macular pigment. That was an initial big mistake, I think. And then, of course, this population was Americans. So they were on all kinds of drugs that reduce the efficacy of nutrients. You know, they were on statins and ibuprofen, aspirin, all these things reduce the efficacy of nutrients. Yeah. And the other point, I think, is that, you know, there's a general view that, and again, not to bash us Americans, but sort of the pill for every ill approach. Yeah. And so, you know, the truth is, every nutritional study really doesn't have a placebo. Even when we do our studies, these people have been basically, you know, it's like, imagine doing a study of statins and everyone is taking statins. And so you pick out a little group and you give them a little bit more statin and then see if it has an effect. So when we do all these lutein studies, people have been on the drug their whole life. And then we give one group a little bit more of it and see if there's some effect on disease. And by the way, diseases that take an entire lifetime to develop. Yeah. So I think it promotes an approach to nutrition that itself is very reductionist and very just take one more pill, and it's probably not the best way to approach any, especially degenerative disease.
Yeah, I agree. Okay, we have some more comments, and we have a lady here.
Aye, the comment about the health service. I mean, certainly in Scotland, we have all the money, and I don't know why we got the money, but we managed to get AREDS1 on the NHS list for people on social benefits. And the groups that you talk about, the people that are needed the most are usually these people that don't look after their health. It'll be interesting to see if AREDS2, because it had to be peer reviewed, it had to be double blind, it had to be random controlled, so we'll see if that actually helps. But that was just a point the gentleman made about the NHS. But yeah, I think you're right, and it's also, I like the statin argument. In Scotland, if you put somebody in a statin, that means they eat more deep-fried Mars bars. You've got to watch that when you put them on something, it's not just a silver bullet. They've got to improve their health, etc., etc., etc. But I think only one thing that's positive about the study is it has raised awareness. So we are having more conversation now with the government about preventative medicine, but NHS doesn't really do preventative medicine, as we all know. That was the only points.
My fear was that, you know, if it had been very negative, it would have killed this area of research, which I don't think would have been good. On the point about getting it approved by local, either health insurance companies or government agencies, the big problem is that these government agencies may find it irresistible, the temptation irresistible to cling on to that primary outcome measure. They just might find it's an irresistible temptation. That worries me about the NHS. But I don't know, hopefully they won't. Hopefully they look into the data properly.
Were they, oh sorry.
Sorry, Alan, yes, you can go ahead.
Were there any studies done on toxicity? If you look at are you going to take 500 milligrams of ascorbic acid for the rest of your life? And we know it causes, in high amounts, causes kidney stones, for instance. And in the case of vitamin E, 400 milligrams is very high. I knew a man who actually took 800. He was one of my colleagues talking about vitamin E, and he died of hemolytic stroke. In fact, there is a danger of taking too much vitamin E. In the case of vitamin C, I think it's probably quite higher than 500 milligrams. At one time, people were suggesting 10 grams or something like that. So my question is, any toxicity associated with taking the AREDS formulation?
You know, if we just go back a few slides there, they say no. So there you go. So lutein and zeaxanthin, yeah, that's mortality. Yeah. Now, there was morbidity in terms of lung cancer and beta-carotene, but that was the only morbidity that was significant. So, and that wasn't even a new finding. So, but I think we can say that in terms of the stringent criteria they use, that the AREDS2 formula without beta-carotene is safe in terms of morbidity and mortality.
Can we maybe go back another slide? Or do you know the vision, the finding around visual acuity? Yeah. Would you have a comment on that, Stephen, in terms of, it's not what I would have expected, in terms of the worse I did best in terms of acuity? Is that right? Am I interpreting that?
No, that's not what it's saying. No, what it's saying is that to end up down here with abysmal vision, you are less likely to end up down there with abysmal vision if you had lutein and zeaxanthin and no beta-carotene.
Okay, it wasn't that it had the effect for that group.
No.
Okay, I think we have another question.
I'd like to make a comment. I think that's an excellent point about the potential toxicity of nutrients and the fact that we started without a true placebo. We started with the AREDS original formulation, which has 500 milligrams of ascorbic acid. So let's look at that one first. The oxidized product of that is dehydroascorbic acid. The secondary oxidation product is oxalate, and it's oxalate that does build up in the kidney, which you're quite correct on that. And there's been a recent clinical trial on high-dose ascorbic acid, and it shows that, yes, the oxalate does build up, but the relative risk, the relative risk, I think, is 30 or 40%, but the absolute risk is very, very tiny. So I don't think that's really a concern. But if you follow the ascorbic acid literature, you'll see that it's probably not necessary to take high doses of ascorbic acid to maintain a very high serum level of ascorbic acid. In fact, it's better to take it serially. So it's not unreasonable if they got 500 milligrams in 2 divided doses, they'd be getting 250 milligrams, but the half-life is only 30 minutes. So there would be periods of the day when the ascorbic acid level of ascorbic acid in the serum wasn't very high. So many of the people doing level 2 science on ascorbic acid today recommend that smaller doses, perhaps 250 milligrams, be taken 4 or 5 times a day to maintain a very high serum level. The problem is no ascorbic acid expert apparently was consulted before they did the design of that study. Getting back to vitamin E, I do think there may be more of an issue with the vitamin E because they used a single isomer, and the vitamin E scientific community tells us that there's 8 isomers of tocopherols, there's 4 of tocopherols and 4 of tocotrienols. And the ones that seem to be of most interest, particularly in smokers, and a lot of people smoke or were former smokers, is the gamma tocotrienols and delta tocotrienols. And so by using a synthetic vitamin E at a very high dose, it may have affected the tocotrienols, which might have more utility with AMD than traditional tocopherols. So this is one of the problems. The problems with doing randomized controlled clinical trials, which use the gold standard, which is level 1 science, is that the science tends to be very slow moving. So the state of knowledge in clinical trials, the state of knowledge in general medicine and scientific inquiry is about every 1.5 years. The state of knowledge is doubling, but the state of knowledge for people who design clinical trials is about 15 years. And I think the clinical trial development is moving much slower than the people like ourselves who are doing level 2 science, and there's many, many studies that are doing great level 2 science. However, that's not typically considered when level 1 studies are designed, and they need to be, because science is ever changing, and so we need to reflect the best formulations. And one other just point, the only other point is that NEI looked at 4 or 5 nutrients. There's about 12 or 14 nutrients that are important in retinal health. And so to only grab onto 4 and not look at the panoply of nutrients that are available in food, I think, is foolish. So we can be doing a lot more for retinal health by just moving away from the 4 that we're using the best science on the 4 and expanding out to 12 to 14 nutrients. Thank you.
Comment. And this lady's been trying to...
Mine's very simple. It's just, you've probably put it up on one of the slides, but what age group was the AREDS2 study done on? What was the age span?
I think they were all 55 and over, possibly 50 and over, but I can't remember.
Thank you.
Yeah, I think the guess would be typically you would develop macular degeneration from 55, 60 onwards, so that would be an educated guess. Have we any more final questions or comments before we move to the next? Yeah, we do.
I wasn't personally surprised. I know a lot of people were personally surprised, but I wasn't personally surprised, because my view is that omega-3 is important because it's an integral part of the photoreceptor outer segment membranes, and that if you have sufficient antioxidant activity, they shouldn't be depleted anyway, and therefore you shouldn't need to replete them. That's my world view of AMD. So I wasn't surprised. I know that people who do expound the benefits of omega-3 have issues with the design of AREDS2 with respect to omega-3s, but it's something it's not my area of expertise. So I think, Stuart, you might have a few comments, do you?
Yes.
Can we get this man a mic?
Our French researchers who published a study at around the same time at Arvo showed that DHA is very important. It's the structural omega-3 that builds up with photoreceptors. So this ratio of EPA to DHA may be very important. But getting back to the design of the study, there was about 750 milligrams of intake of omega-3 in the highest quintile of the control group. So when you're trying to tease out the difference between people taking that level, and in the United States, I think the average is about 150 milligrams or so of intake of EPA and DHA. So the control group had 5 times the level that the average American had, and we're trying to tease out.
Yeah, so it's the same problem. It's the same problem, yeah. Alan, you want to make another point?
Yes, I wonder whether you could explain why they included copper in the original AREDS formulation. The reason I say this, I worked for 10 years on ascorbic acid in my original research, and I found that one of the things which destroys ascorbic acid, in fact, is copper sulfate. And obviously it dissolves in the stomach as forms copper chloride. And I imagine there'd be very little ascorbic acid left by the time it passes into the rest of the intestines. So if I was doing this, I wouldn't add copper because I can't see what function it serves.
Stuart agrees.
I agree 100% with you on that, in fact.
But the reason...
In the RPE, they find hypermineralization. They find higher levels of copper. We find higher levels of copper not only in the RPE, in brains with Alzheimer's disease. It is an oxidant. And one of the ways they originally came up with polyunsaturated fats is they dropped a copper disc into a vat of saturated fat, and they can create artificial oils. It's very, very strong oxidant. So I absolutely 100% agree. They only did it because of the high zinc levels.
That's right.
So this issue about how much zinc to use is critically important, because it might be, we might be able to lower the amount of copper, which is an oxidant we're going to be looking for.
Yeah, I think the reason they included copper was to offset a copper deficiency that comes with zinc supplementation. Isn't that right?
Yes.
Yeah. So that's the reason. They gave the copper to prevent an anticipated copper deficiency that you get with zinc supplementation.
Thank you, Alan.
Just, so we're going to design AREDS2 study. So how would you do that?
AREDS2 study.
What I would do with an AREDS3 study would be very simple. It would be the new AREDS2 formula versus the new AREDS2 formula with 10 milligrams of mesozeaxanthin.
I think that's, unless anyone has any, because this has been a good discussion, an important discussion. Has anybody else got any final comments? No? I think we'll move to the next session.